Welcome everyone to our last breakout session, an equity approach to addressing childhood trauma with Iowa ACEs 360. This presentation will explain the impact of childhood trauma on Iowans' lifelong health and how historical and societal factors contribute to those who experience poverty. Our facilitator, Lisa Kushat, is the director of Iowa ACEs 360. ACEs 360 seeks to improve the health and well-being of all by empowering communities, organizations, and people to take informed actions to prevent and mitigate the lifelong effects of childhood adversity. Lisa is also an adjunct instructor in the human services field and previously served as the executive director for United Ways of Iowa. She has a master's in social work with an emphasis in policy, planning, and administration from University of Missouri-Columbia, as well as her bachelor's in sociology from Truman State University. Just as a quick note, we ask that you do keep your microphones muted while our speaker is talking, but feel free to unmute yourself and join the conversation when prompted, as well as using the chat as you see fit. Thank you all for being here, and I'm very much looking forward to our conversation. Lisa?
Great. All right. Well, thank you. And thank you for the invitation to present here at the Hunger Summit today. I'm really excited about sharing what we're doing, not only as a network, but where we really see the ACEs movement going, not only here in Iowa, but nationally and internationally as well. So our focus today is that more equity approach on addressing childhood trauma. As Madeline stated, our mission is really focused on taking informed actions as research-informed work towards that prevention and mitigation of childhood trauma. Now, what I would like to do just to start off is if you could look at the little button that says reactions at the bottom of your screen, and give me a thumbs up, a smile, or something that lets me know how many of you have heard a basic presentation or know basic information about adverse childhood experiences. Good. Great. Thanks, folks, for doing that. That just gives me a little understanding of where we're at today and how much information I should share. So while I'm not going to do a full ACEs 101 or core training today, I am going to give you a bit of background on brain development and ACEs for the context of our discussion today. And what I'm going to start off with is talking about nature versus nurture. So for many years, we had this public and private debates around the kitchen table around whether it is nature or nurture that impacts our health, our well-being, and who we grow up to be. And the truth is that it is both. Think of genes as providing our basic blueprint, but our experiences and our influences as shaping how we interact with the world. So according to the Harvard University Center on the Developing Child, learning how to cope with things like stress, adversity, how we interact with the world is a very important part of childhood development. If we feel threatened, our bodies help us by in our response by increasing our heart rate, our blood pressure, our stress hormones. When we have young children that experience stress in an environment that has supportive adults, supportive relationships, supportive systems around them, the effects of that stress, that adversity are buffered, and our brains and our bodies naturally return to a baseline, and we learn how to regulate and manage those experiences. This really helps a child develop a healthy response to stress. Yet when a child experiences stress that is powerful, frequent, or prolonged, or it's unpredictable, it can become toxic stress. So the brain architecture, our physical systems can actually be altered and their development disruptive. An overactive stress response system can have a lot of impact on our long-term health, how we behave, how we focus, how we act. And over time, this level of stress can lead to poor health, learning and social and negative social and health outcomes. So again, really, it is our not just our genes and our nature that impacts us, but it's all those experiences, good, bad, or otherwise, growing up that really shape how we interact and react to the world throughout the course of our lives. So that's the foundation, some of that core foundation around brain development, which we want to base our conversation off of today. Now, when we look at the term adverse childhood experiences and what we mean by that, that leads us to talking about the landmark adverse childhood experiences study. The original ACE study was conducted in the 90s. It was the largest study at the time looking at the short and long-term impacts of cumulative childhood trauma ever done. The study really set out to examine the relationship between adverse childhood experiences, or what we call ACEs, and later health and behavior outcomes. This study is one lens that we can use to look at the long-term impact of trauma and stress. Now, when we say the term ACEs, and we talk about childhood trauma in reference to that original study, they defined ACEs as 10 incidents that dramatically upset the safe, nurturing environments that children need to thrive. The original study focused on the 10 types of trauma you see listed on the screen. But it is really important to note, and this is what we're really going to go into later in our discussion today, is that trauma is personal. What is traumatic to me may not be traumatic to you. This list does not include every type of trauma or account for the frequency in which trauma occurred or the severity. It's whether did any of these things occur at least once. So the original study was conducted by Dr. Vince Felitti, who was founder and chief of Kaiser Permanente's Preventive Medicine Department in San Diego, and by Dr. Robert Anda, who was with the CDC's Epidemic Intelligence Service. And Dr. Anda in particular, he's been to Iowa and the Midwest several times. So many of you may have, I assume, have probably been at a conference or a training where he's presented out before. The original study, again, back in the 90s, included more than 17,000 members of the Kaiser Health Plan in San Diego. These individuals filled out a survey measuring the number of ACEs. So did any of these 10 incidents, things on the screen, happen to you at least once? Then from there, they did comprehensive physical and mental health evaluations. They took all that data and then looked at the relationship between experiences of adversity in childhood as reported by adults and later health issues. It's important to note that this original study, the majority of study subjects were educated, middle class, predominantly white. So the study's findings were shocking. First, they found that ACEs were common. Nearly 2/3 of their original study participants had experienced at least one type of trauma. They also found that ACEs tended to occur in clusters, which meant if you experienced one type of trauma, there was a high co-occurrence with other types as well. And then finally, they found that as the number of ACEs increased, so does the risk for a range of physical and mental health issues. The study showed this link between between childhood adversity and some the health and social outcomes related to some of our most costly health issues today. So when you turn on the news, when you're at your doctor's office, these are some of the health issues that we frequently discuss and their long-term impacts. Many of the health issues where they found this relationship were related to the adoption of health risk behaviors. So for example, if you smoke, you're more likely to develop COPD. But some of the issues were unrelated. So for example, researchers looked at pulmonary and heart diseases not related to health risk behaviors, and they still saw an increase in risk related to some of our, related to the number of ACEs. So this was really the first time that we've been able to correlate some of our major health issues with incidence in childhood. Now, if you're like me, and I know many of you today that are joining us have worked in or volunteered in the health and human service field for a number of years, and we intuitively knew this information. What the ACE study really did is provide some of that science and that research to back up what we knew was happening in health and social outcomes for individuals who are experiencing trauma. Now, what you see here on the screen in the chart on the right is what we call a stair-step or dose-response relationship. So as the number of reported ACEs increases, so does the risk for many of the negative health and well-being outcomes. So that stair-step, or what we call a dose-response relationship. So when we look at this, in fact, through the CDC, through all the research that's been done related to ACEs since that first study, they have found a lasting impact in many areas beyond risky behavior and chronic health. This tells us that yes, indeed, ACEs is a public health crisis. The thing is, though, that the original study and some of the subsequent studies immediately after were all based on national data. But here we are in Iowa, and sometimes we like to think that things like childhood trauma do not happen in our state. And those of you who are from different areas, you probably have a similar reaction. Folks say, yes, I know it happens, but not in my community, not in my region, or it's not as frequent. So here in Iowa, back in 2012, we started collecting data on adverse childhood experiences. This is collected through the Iowa Behavioral Risk Factor Surveillance System, which is administered by Iowa Department of Public Health in partnership with the CDC. It is a voluntary, confidential phone survey that's administered to a representative sample of Iowa's population. Now, the Behavioral Risk Factor Surveillance System is a large data set that includes a number of things in it, of which ACEs is one component. We at Iowa ACES 360 specifically focus on not only the questions related to adverse childhood experiences and neglect, but we also look at mental health concerns, data around resilience, as well as social determinants of health. So what did we find? We just a couple weeks ago launched our 2020 Iowa ACEs report. And similar to previous reports, and similar to what is found in any analysis that's done around the country, we find that Iowans, the majority of Iowans, experience childhood adversity. 63.7% of Iowa adults will report back and saying they experienced at least one type of ACEs or neglect in their childhood, so before the age of 18. So of those 10 ACEs neglect on that original list I showed you, at least one of those things happened once in their childhood. We also in particular look at 4 or more ACEs. It doesn't necessarily mean that there's increased risk, but it does show that there is a cumulative amount of trauma impacting individuals. So the red piece of our pie chart there reflects those who report they experienced 4 or more incidents of ACEs or neglect in their childhood. And that's 16.7% of our adult population. So again, this impacts everywhere in the United States, and it certainly impacts here in Iowa. We also, with our latest report, looked at the prevalence across regions. So in our 2020 report, we looked at the percentage of Iowa adults by public health region who experienced 4 or more ACEs. Now, I want to be clear, this does not tell us where the trauma occurred. It tells us where adults who are living, working, engaging in our community have experienced higher levels of trauma. We look at this just to highlight that there, again, is significant need in our adult population who have experienced trauma themselves. We also find in looking at health conditions in our state, the same dose response or stair-step relationship between the number of reported ACEs and neglect to long-term health issues. This is an odds ratio, which means an odds of 1 is that an individual reports 0 ACEs. So adults with 4 or more ACEs, or as you can see in the red bar there, have increased risk for a number of health issues. So the couple data points that I like to pull out here on this chart are 1, COPD. Adults that report experiencing 4 or more ACEs are 5 times more likely to have COPD. For those that report 4 or more ACEs, they're more than 7 times more likely to have depression. Okay. So again, we see that same stair-step or dose-response relationship in our Iowa data that you see in national data and other data sets as well. I noted that we also look at mental health data. We continue to see, again, the same dose-response relationship related to mental health. Now, I want to be clear, trauma is only one of many contributing factors around mental health, but it is really important area when we're looking at prevention and mitigation of mental health concerns. More than 35% of those who reported at least one mental health concern also reported experiencing 4 or more ACEs. So you say, Lisa, I'm at the Hunger Summit. I want to know how this impacts what we're talking about today and the overall context of this time we have together. So I mentioned that we also look at social determinants of health in this most recent report. This is new. This is something that we have not done in previous reports. And there are a couple questions specifically related to hunger that I think are helpful to look at in relationship to ACEs. So in the data, in this survey, they ask adults in the last 12 months, have you experienced or would you report any of these concerns around social determinants of health? And there are 2 questions in those directly related to hunger, as well as some others related to poverty that I think have an impact. But I'm going to focus on the 2 that are directly related to hunger. So for Iowa adults who reported that in the last 12 months, their food didn't last and they couldn't afford more, over 27% will say that they experienced 4 or more ACEs in their childhood. For adults who reported that in the last 12 months, they couldn't afford balanced meals, 33% will say in their childhood they experienced 4 or more ACEs. So you're going to ask, Lisa, why is this? I don't get it. I see the numbers. I see the stair-step relationship. Why is there a link between hunger and the food challenge, between trauma and the food challenges we see today? The answer is that beyond that original ACE study, beyond the household trauma we originally looked at, we need to take a more comprehensive, equitable look at the broad scope of the contributions to trauma in order to understand why there's this relationship between trauma and some of our social determinants of health. So I'd like to have a bit of a discussion here. So these are our original 10 ACEs, the conventional ACEs in the original study, what Iowa focused on in their first few reports. But I want to ask you, what are the challenges with these original 10 ACEs? So just type into the chat box, what are some of the challenges with these original 10 ACEs? And I see there's the question on how many people took this survey, and I can get you the exact numbers. There's the population for overall behavioral risk factor surveillance system, and then depending on the year, not everyone's asked the same questions, and so the population for these particular questions is a little bit smaller. So what do you think some of the challenges are? Great. I see a couple comments coming in. That's great. I'm going to give it just another moment here to see some of the more of the feedback. Mhm. Yeah. Yeah. Yes, thank you for that feedback. So a few things that were noted here, and then I'm going to share some of the others as well. One is self-reporting. So this is a voluntary confidential phone survey of a population. It's going to include anyone that's an Iowa adult from age 18 to the oldest Iowan. So one, there's a generational impact of that. What I may consider to be traumatic is going to be different than my mom's generation versus my grandmother's generation. It wasn't even until the 70s that we had significant reporting around child abuse and definitions of what it was. So we look at that impact over the course of generations and how we consider it. There's also, as someone noted, that community stigma around it. How does it reflect to me and my family and over the course of generations? We also know, as some of you noted, what resources were available, how that trauma may have been impacted, may reflect how they view it today, and some of the accesses to other supports in the community, such as food access, such as family services, such as services in the school can all impact it. So thank you for that feedback. So while ACEs gives us this framework, this wonderful framework for understanding trauma and its long-term impact, we know there's a lot of major stressors beyond this list of 10 that we see on the screen. So a few of the overarching reasons why there's challenges with the data. And I'm saying this, I work for ACEs 360. So this is me sharing with you that there are challenges in looking at it in such a strict way. One is that ACEs are not comprehensive. So they don't include every type of trauma. And again, what may be traumatic to me may be different to you. We have those differences in what we had access to and over the course of generations and how we personally view things. The second thing is that ACEs largely focuses on trauma internal to the home. Things like this can be seen as parent blaming, a focus on that family dynamic or their values. So only focuses on things internal to the home. The data then does not connect to trauma that's caused by systems, by community issues, and it certainly doesn't take into account historical trauma, epigenetics, and social determinants of health, things like poverty and hunger. So when we look at this sole focus on household trauma, we actually believe that the rates of childhood adversity, as reported by adults, is actually underreported. And other communities have found this in research. So for example, one of the studies that I often point to is out of southeastern Pennsylvania. And they found in their survey respondents, 13.9% only experienced trauma external to the home or out in the community. They would have missed 13.9% of the population who is experiencing trauma if they only focused on what was going on in the home. They also found in research out of that region that there were clear differences in ACE exposure based on demographics. Gender, race, poverty were all associated with higher rates of exposure to the expanded or more community level trauma that individuals faced, as opposed to this household trauma. So when we're looking at trauma response movement in Iowa and beyond, we have to expand our framework and adjust what we're looking at. And so that's what we're going to do here for the remainder of our time today. And again, I have a number of more points around discussion that I'd love to get your feedback on and hear more what you're thinking. So now let's talk about this new framework where not only where we're moving as a state, but I believe nationally and internationally, where a child trauma response movement is moving towards. We're going to look at a framework that fuses community conditions and is rooted in equity. This doesn't mean we don't address the household internal trauma. It is about expanding the framework beyond that sole focus. Now, I am going to be honest with you. I don't claim to be an expert on equity. And I'll tell you, our coalition, our organization we work for, we have a really long way to be equitable in our work and how we're presenting it. So we are still learning. And again, I wouldn't say we're anywhere near being an expert. But why we want to have this discussion now is shifting the framework and how we're doing work, because we know not only us, but the whole health and human service field, our systems like our food serving systems, are not rooted in that view of equity, and we have to have that framework in order to be able to move forward and actually prevent and mitigate the impact of trauma. So my goal today is really to explain this framework and invite you to work with us, work with your partners in your community in that equitable response to childhood trauma. So when we look at what this means, and again, for those of you who have been part of ACE's trainings before, heard presentations, depending on how recently you heard those, this may be new information. So what you see here is the ACE pyramid from the CDC. It illustrates how ACEs impact the life trajectory from birth to death. So according to the CDC, the link between ACEs and later health and social outcomes help to explain a scientific gap. Research in the 80s and 90s showed that risk factors like smoking, alcohol use for many, and other factors for many common diseases were not randomly distributed, and that a lot of the risk factors tended to cluster. So that meant if they had one risk factor, they had others. What the ACE study did is provide that link between childhood trauma and these risk factors. The pyramid explains the theory, the thought process for how we see that long-term impact on health and social outcomes, that it happens through potential disrupted neurodevelopment. For some folks, that will then lead to social, emotional, cognitive impairment, and then adoption of risky health behaviors, which leads to disease, disability, potential social issues, and yes, early death. But what we have seen nationally and what we're doing in Iowa now is the addition of these two bottom layers of the ACEs pyramid. So previously, we talked about the impact with trauma and that household trauma as the start. The ACE pyramid reflected on this slide is the most current pyramid from the CDC. It adds two layers at the base of the pyramid. It's really crucial in this work that in order to understand the connection between trauma, social conditions, generational or historical trauma, this pyramid highlights that social experiences outside the home, community level experiences, and our systems all have a significant impact on the health and the well-being of kids and families. So if we're going to disrupt trauma, we have to address these foundations in which our families are living in this state. So what you see here is the framework that we really focus on here now in Iowa. It's adapted from Wendy Ellis's pair of ACEs. In the evolution of ACEs research, it was clear, again, that we were missing a significant amount of trauma by only focusing on the home. From things like racism to homophobia, from medical trauma to poverty, we need to have a much more comprehensive approach. So what you see in this graphic, again, based off of Wendy Ellis's pair of ACEs, is a more holistic view of everything that contributes to childhood trauma, including community, environmental, and household trauma. And I think in a year where we have a pandemic, a year where we have natural disasters, and in a year of anti-racism work, that we can see the critical nature from an environmental and community perspective in this conversation. Here are some of the common areas that we see ACE's data collection occurring related to environmental and community trauma. So things like experiencing discrimination based on race, sexual orientation, place of birth, disability, or religion. Not feeling safe in your neighborhood, maybe not trusting those that live around you. Have you experienced community violence? Have you experienced gun violence? Bullying, whether it's inside the schools or out in the community. Individuals who've been involved in foster care. The original ACE study only looked at loss of a parent or guardian due to divorce or separation. It did not include loss of parent or guardian due to death. We also look at deportation or migration. Alexito here in Iowa has some great information collected by students on the impact of deportation and migration, the traumatic impact of that on their youth and on their youth's mental health. We also look at things like medical trauma, natural disasters. So these are some of the things we're seeing collected more frequently. In Iowa, we have a ways to go in getting this robust of a data collection, but that's where we're building in some of that social determinants of health data now in our analysis. So let's discuss. I'd like for you to throw into the chat function, what else would you consider trauma? You can be more specific than some of the things on here, other areas you think are missing. So throw into the chat box, what else should we be looking at as far as that environment or community trauma? Mm-hmm. Yep, parent with a terminal illness. Mm-hmm. What are some other thoughts? Mm-hmm. Homelessness, yep, yep. Illnesses that are impacting a family member or themselves. Absolutely. Other thoughts from the group are what other types of community or environmental trauma? Yeah, absolutely. COVID, a global pandemic. We talk a lot about how this is affecting kids' access to school, their academic learning, their mental health. We really should also be talking about what is the impact of this collective global trauma on all of us. How is that going to impact for generations to come? Yeah. Witnessing violence. Yeah, absolutely. So we talk about that community violence. We talk about gun violence. We talk about violence in the neighborhood, violence that they may vicariously be experiencing through those that they care about in their life. Pollution and forest fires, absolutely. Up in Michigan, where they're looking at water quality and access to clean water and the trauma that that is having on kids and families, not only on their physical health right now, but how the stress of the, do we even have clean water? Do we have clean water to clean our kids' baby bottles, to have basic hygiene and clean water to drink? The impact of that over the course of generations, and other areas of pollution or climate change. Yeah, that note that in addition to sexual orientation, gender identity, and being very clear how that is impacting, particularly from a systemic perspective, how that's impacting. Yeah. Yeah. The impact of just how folks view you based off of who you are and what you wear. Yeah. Yep. Absences due to military deployment, absolutely. Impact of war. There are, when we look at collective trauma, there's some specific research around those who are refugees and the impact in going through not only the process to come to the US, but having that experience of collectively being persecuted due to religious or political stances. Yeah. And just some folks know, just living in a home with a poverty level income. So what is it like to just day to day not be able to focus on the mental health concerns, the physical health concerns, because your core focus day to day for you and your family is, do we have enough food? Are we going to have a roof over our heads? So in that Maslow's hierarchy, those basic survival things, and if that's all you're focused on, there's going to be a real concern. So thank you, everyone. That was a great discussion. I appreciate it. So these are emerging awareness. This is where we need to go and we need to aspire to be, and really better understand what this long-term impact is. Now, we do have some of this in the updated Iowa ACEs report. We still have a lot of progress we need to make in how we do this. But here's some of the data. So trauma impacts everyone across racial, socioeconomic status. But we find, similar to other studies, that there are particular groups that experience 4 or more ACEs at higher rates. And that includes adults of color, women, those with less than a high school education, and those below 184% of the poverty level. And the chart you see on the right shows you that reverse stair-step relationship related to federal poverty level. So why is this important? It's to note that this isn't just about what goes on in the home. These groups are not, trauma does not only happen to individuals who are below the poverty level, but they're experiencing higher rates because of those systemic and those community level traumas that are building a foundation for their environment. So when we look at the impact of trauma, and when we look at the data that we have available, both current child abuse data and data like our ACEs report, that it's adults reflecting back on what happened to them in childhood, that impact of it from the policies and systems down to our organizations, down to our families and children. And while we really want to focus on the impact on kids and families, any data we provide is a point in time snapshot of individuals responding to a survey. So we really want to look at this less about specific percentages and look at what is that impact on not just the family, but the conditions and the contributing factors that impact that family and their foundation. So when we look at strengthening our communities, and what does this all mean, and looking at the emergency awareness, where do we go? What does it mean? When we respond to childhood trauma, we have a tendency to focus our responses on the child and family. And we do the same thing in response to things like poverty. We focus on how do we get programs and services so that that child and family can have what we need. But that has its limitations because we're not actually addressing the conditions which led to hunger, which led to trauma, which are creating that foundation for challenges for families. So when we look at how we move forward in our state in addressing, and nationally in addressing childhood trauma, it's important to note that addressing childhood trauma cannot occur without disrupting the systems that cause inequities. Anything but addressing those systems is to some extent going to be Band-Aid approaches. Trauma-informed care cannot occur in the absence of equity and anti-racism efforts. So when we look at this and what this means, we have great direct services in Iowa. Nationally, we know what wonderful trauma-informed mental health interventions are, what trauma-informed schools could and should look like, what trauma-informed child welfare could and should look like. We know all that. But doing that alone does not address the systems that causes the inequities. So when we are approaching how do we respond to childhood trauma, we really need to be looking at these 2 layers as well. Again, we have to look at the family. We have to look at the impacts on the child. We have to have the wonderful direct responses and interventions that we have now, but we cannot do that in the absence of looking at organizational responses and policies and systems and communities that contribute to those conditions. And I really emphasize here, not just policy systems and communities, but our organizations in and of themselves. Again, I love the health and human service sector. I've worked in it my entire career, as I'm sure many of you on the conversation here today have. But what we know is that our organizations sometimes re-traumatize and perpetuate the conditions. So again, if we're taking a trauma-informed approach, it has to be based in equity, based in anti-racism work, addressing poverty. So what does that mean? Where do we go from here? How do we do this work? And so the first thing we can really do is infuse critical concepts. The mode of crisis that we're in with this pandemic and the community concerns that are really rising to the forefront that many of us maybe we're not focusing on before, really pushes us to elevating these concepts that you see on the screen. So things like collective trauma. Collective trauma is a large-scale shared trauma within the context of our time. So that's things like a pandemic. Historical trauma. When we look at collective group trauma accompanied by grief, that's passed along generations. Things like chattel slavery, things like discrimination of our indigenous communities, the loss of land, the impact on disruption of families. When we look at epigenetics, while our basic genetic makeup may remain the same, our environment can impact what aspects of ourselves come out and are focused on, and what stressors and health impacts we may have. With equity, equity is really everyone having what they need to have access and opportunities and a fair chance to succeed. It's really about recognizing that the same for everyone. Phrases like equality doesn't truly address the needs of individuals. Health equity, accompanied by addressing things like existing and systemic inequities in our society that drive poor health outcomes. And equitable recovery, and we particularly are talking about this in terms of pandemic recovery today and collective trauma recovery. Our efforts really should prioritize the populations more at risk and address some of those existing and historical systemic inequities, so that once we get past the pandemic, once we get past these challenging times, that we're not just jumping right back into systems that started the inequities in the first place. So these are some of the core concepts. If you're interested, for you or your organization, there are some wonderful folks in Iowa and throughout the country who do really in-depth trainings on these concepts that we would highly recommend. So my question to all of you is, what are the challenges with infusing some of these critical concepts? What are some of the barriers in bringing equity to the focus of childhood trauma? What are some of the things that you see as challenges with infusing these concepts? Yeah, there's the core issue with many don't believe that inequities exist. And I think that there is that work that we do within our communities and within our organizations where we need to continue to highlight where they exist, because we can't get towards disrupting these systems unless we highlight them. What other challenges do you see? I'll tell you some of the things that we're hearing from our partners right now, and someone just noted it, is things like funding and time. We are in a crisis situation right now, kind of no matter where you are working. And when we are in this time of trying to focus on immediate needs, um, these larger concepts can get lost because we're trying to address the need right now, that survival instinct, remember? And so it's difficult to, while do that, at the same time say, and these critical concepts have to be included. But it gets back to that idea of equitable recovery. Funding is such a huge issue. And so we are really focusing on our resources. That doesn't absolve us of our responsibility to deal with the critical concepts. And how can we help our leaders understand that? Policy changes, absolutely. Both nationally, state, locally. In order to infuse these, they require that our policies take these into account as well. That our policies require and have that reflection of these critical concepts. Those siloed funding streams, when we have leaders from all aspects of life that, or from all levels, whether it's organizational, whether it's government, who don't want to include these concepts. Yeah, so thank you. So there's definitely challenges with infusing these critical concepts. And my charge to all of you is that we cannot allow these challenges to override our work in actually doing them. Because again, if our goal is to prevent and mitigate childhood trauma, if our goal is to impact the number of kids and families who are facing poverty, who have low access to food, we have to disrupt those systems. And have to have an equitable approach in disrupting those systems, or we're not going to make the movement we need, and we're not going to be true to our missions. So what does this look like? Now, again, remember I said, and I'll say over and over again, I'm not an expert. We are still learning as ACES 360. We are still learning with partners. We still have our colleagues coming in and helping us really chart the direction around this. But I'm going to give you a few examples that have been things that our partners have talked about, things we've really focused on in our work. So child abuse prevention is an incredible field. There's a lot of great programs in our state and throughout the country. But what we have to be careful about is those solely focusing on just what's happening internal to the family. We have to step back and say, in looking at how to support that family, how has historical trauma impacted our systems? Is there systemic discrimination in child welfare that's creating these inequities, which yes, that has occurred over time in our policies? How is implicit bias impacting how we view a particular family? So it's not just about the prevention activities, but taking that broader look at all those community environmental conditions, in addition to any childhood trauma that's happening in the home, to addressing and creating that prevention. Again, mental health interventions, trauma-informed mental health interventions. We have some great things being done in our state and nationally around those trauma-informed interventions. But what we need to do with those great interventions is assess the effectiveness for diverse clients. We need to diversify our workforce and our organizations and our systems to be reflective of our community as a whole, to make sure we are best serving folks from a variety of backgrounds, and making sure the interventions we are doing are not solely a Eurocentric approach. When we look at maternal health access, Maternal health has been a huge conversation over the last few years. Prenatal supports was a session earlier this week. When we look at that maternal health access, sometimes we go laser focused to things like access to physicians, access to birthing centers. And those are critically important, right? I would never say those aren't important. However, if we're going to deal with maternal health disparities, we can't just say, oh, it's about access. We have to say, what does discrimination look like in our healthcare systems and with providers? Are we providing supports for families before birth to make sure that families have all of they need ahead of time, rather than having a condition of trauma as soon as kiddo is born into the world? So we have to take that bigger look than just saying, oh, it's all about access, because it's one piece, but it's not the only piece in disparities. When we look at disaster recovery or pandemic response, we go to let's making sure everyone has equal access to what they need. But when we do that, and we do that in disaster recovery or pandemic recovery, we're neglecting the fact that there were some folks who are disproportionately impacted by this disaster, that are disproportionately impacted by the pandemic, and they're going to need more intense supports, and our policies and our relief systems need to allow those more intense supports to be available. And then the other thing is around focus groups and community conversations. And again, I love the health and human service sector. I wouldn't have worked in it my whole career if I didn't. But when we look at how do we engage the community, focus groups, community conversations, they're great. But what we really need to do is how are we having power in decision making? So it's not majority, minority populations asking what certain groups need and then making decisions on what those final strategies are. We need to have that power in decision making and have our communities really leading what that work looks like, having youth voice in our work. So if we're dealing with hunger issues for youth in our schools, who should be involved in those decisions? Not just the administration of the school or community leaders. We need youth crafting what they need, and we need to be listening to them. And again, just leadership from those who are most intensely experiencing trauma. Without that voice, beyond just asking questions to them, without that voice and leadership, our systems are going to continue to perpetuate the trauma that we see. So again, I know we have so much more work to do in this area. There are a lot of incredible folks around equity work in our state, in our region, and in our country that I'd really encourage you to connect to. What I really, again, want you guys to take away from here is it's about you and I and our partners and our organizations shifting our framework from saying this is just an issue about internal to the household to it's just from the household to the community and to those environmental impacts, because all are important and all contribute to that long-term health impact. So these are, before I open it up for questions, I just want to throw out a few ways you can get involved and learn more about this work. Our website is listed here. You can sign up to receive ongoing updates on our trainings and our work, or if there's specific areas you're interested in, we do have some specific newsletter sectors. We were also fortunate to have a wonderful speaker, Ingrid Cochran, back in June, who led us through specifically around pandemic response and equitable response. Really going through in detail around collective trauma and equity. Her learning series is on our website if you want to learn more, and there's a really great learning guide with ideas for books and engagement and terms that you all can have access to. We also have regional advocacy events going on across the state right now. If you are interested in having a voice in what the systems change should look like. We are trying to engage from every part of Iowa. What are the challenges with the systems that we need to disrupt, so that when we look at the regional level or we look at the state level, it's not just those of us in the Des Moines area deciding what that should look like. We want to hear from the state as a whole. And then finally, and probably most importantly, take this framework and really advocate within your organization, within your community, and really pushing that shift, and then allowing and sharing the power with those who are experiencing trauma to guide where work should go and what those systems should look like.